I'll do this or this.
Okay, welcome back, everybody. Hopefully you can hear me. Sorry for the technical difficulties there. We're having a little trouble with our volume on this side. Please chime in and let us know if you can hear me this time or not. We're getting a lot of feedback that nobody can hear any volume. So let me just introduce myself here and welcome to everybody who's joining us today. For those of you who are joining for the first time, my name is Dr. Jamie Mitchell. I'm an endocrine surgeon and I'm the medical director at the Norman Parathyroid Center here in Tampa, Florida. The busiest parathyroid surgical practice in the world. And we are fortunate enough to operate at the Hospital for Endocrine Surgery, a one-of-its-kind hospital dedicated entirely to the care of the endocrine surgical patient. In addition to the Parathyroid Center, we also have the Thyroid Cancer Center and the Adrenal Center, which are in their own respects the highest volume centers for the care of those types of patients as well. A quick review of my background. I went to a small Jesuit undergrad school in Massachusetts and then went to Georgetown Medical School. I decided to do general surgery training at a Harvard program in Boston for 7 years after that, and then did a fellowship training at the Cleveland Clinic in Cleveland, Ohio, where I stayed as an academic surgeon for about 10 years before joining this practice. And with that, again, please give us some feedback if you can't hear me. We'll start with your questions, and thank you to everybody who was kind enough to send some questions in today. First question we have is a two-part question. First, during surgery, when each gland is located, are you definitively able to tell if the gland has become abnormal or not? If two glands are removed as adenomas, is there a chance the remaining two will become abnormal in the future? Both good questions. The first question is, yes, we can tell definitively if the glands are abnormal or not. How do we do this? There's two things that we do to evaluate the glands. The first is just a visual inspection. Abnormal parathyroid glands, parathyroid adenomas are very different in appearance to normal glands. Normal parathyroid glands are very small, as many of you probably know. They're about the size of a lentil or a grain of rice. A typical parathyroid tumor is probably about the size of a lima bean. And so, while still pretty small, these are very different in appearance, very different in size. So visually, you can usually tell the difference. However, sometimes the abnormalities can be a bit more subtle. Excuse me. And so that's where our functional evaluation becomes really important. And so we're able to test the function of those glands based on how much of the radiopharmaceutical or the tracer that those tissues absorb when you get the system EB scan, which we do before all of our surgeries. Tissues will absorb a variable amount of that tracer based on their function, and that's something that's measurable. We can measure the amount of radioactivity in those tissues, which determines whether the tissue is hyperfunctioning or abnormal or whether it's normal. This is what we mean when we call our surgery radio-guided parathyroid surgery. People often think it means that we use a probe to look around or the neck and try to find abnormal glands, but it's not location guidance at all. The guidance is decision-making guidance. And so when we identify a parathyroid tumor, that measurement's not really a game changer. They're obviously abnormal and these are removed. But when a gland is maybe borderline in size or looks even pretty normal visually, but when we do the functional test, it measures much higher than normal, then it's, even though it looks pretty normal, it's functionally abnormal. And that measurement guides us that that gland needs to be removed. So that's really what radio-guided parathyroid surgery means. And that's how we determine or evaluate the glands for whether they're normal or not. Second part of the question, if two glands are removed, is there a chance the remaining two can become abnormal? The answer is yes, it's possible. It's pretty unlikely, pretty rare for that to happen. It's maybe 1 or 2% of patients develop recurrence over the course of their lives. The most common reason for people to need a second operation is when patients undergo more focal parathyroid operations where all 4 glands are not evaluated. That's one of the reasons we do that here, to try to avoid, whenever we can, the need for a second operation. This is a similar question. I had primary hyperparathyroidism in 2014 with the removal of 2 adenomas. Should I continue to have yearly lab checks of my PTH along with calcium? What are the risks of me developing another adenoma? And there's a third part to this question. I was told I should take calcium supplementation for the rest of my life. Is this true? Really, you should continue to have a calcium checked yearly with your annual physical. That's really all you need to do. Okay, if your calcium starts to become elevated in the future, then parathyroid hormone levels should be measured as well to try to determine if the hypercalcemia is parathyroid disease recurrence or not. More complicated evaluation, lab evaluation, for example, doesn't really need to be done. So just a simple calcium with your annual checkup is adequate. What are the risks of me developing another adenoma? We talked about that already. It's pretty rare. 1 to 2% of people will develop another or develop recurrence of another adenoma after a successful operation. Calcium supplementation is helpful after surgery for a couple of reasons. In the short term, the first couple of weeks, calcium levels tend to run low. So we always supplement our patients with calcium for 3 weeks after surgery because you can get symptoms from low calcium just like patients get symptoms from their calcium being too high. Calcium supplementation mitigates that, but it's a very short-term issue. A lot of patients with this disease have bone loss. That's one of the things that parathyroid hormone overproduction can cause. And so it's not a bad idea to continue calcium supplementation in those patients, sometimes for even a couple of years, because providing that extra calcium and other mineral that goes into bone is helpful to help the skeleton regenerate itself or get back some of its lost density in the ensuing years after surgery. Do you have to take calcium for the rest of your life? The answer is no, you don't. A couple of years can be helpful though, okay? Next question, what are the most reliable imaging studies to find my parathyroid adenoma? I've heard about sestamibi scans not being that accurate. It's a great question, okay? The reality is there aren't any great imaging tests for seeing, for imaging abnormal parathyroid glands. This patient or person mentioned sestamibi scan. That's a common imaging test used in the perioperative management of parathyroid disease. But the sensitivity, like all imaging tests, and what are the other ones? Ultrasound, CAT scans, these are the common tests, imaging tests that are done to try to identify the location of an abnormal parathyroid gland. None of them are very good. The sensitivity is relatively poor. It's around 50 to 60%, which means almost half of patients who have parathyroid disease, nothing shows up on the imaging tests. In general, it shouldn't be a problem or shouldn't be an issue. Imaging tests are not used to diagnose this disease. They're not used to determine whether this disease should be treated or not. And that's one of the reasons that we always identify all 4 glands when we operate on patients, because imaging tests can be very misleading and unreliable. They're a tool that we use as well, but it's not to determine which gland needs to come out. That's determined when we examine them during the operation. And it's an important distinction because many surgeons in this country who perform parathyroid surgery use imaging tests to tell them what operation to do. And because of the poor sensitivity and poor specificity of imaging tests, it's a bad way to approach this operation, okay? Here's a question concerning reoperative parathyroid surgery patients. For your redo patients or patients who have had previously unsuccessful parathyroid operations, did they have 4D CT scans and sestamibi scans prior to their earlier surgeries? If so, did they fail to show the bad glands? I'm wondering why so many patients end up needing additional surgeries if they are having the proper scans preoperatively. It's pretty much the same answer that I just went through with the previous question. Most of these patients, yes, they did have imaging tests, but imaging tests can be really misleading. Most of the patients who have had unsuccessful surgeries have had a surgeon who utilized the results of imaging tests to tell them what operation to do, and they were misled by the findings. Or, sometimes surgeons are just relatively inexperienced and they just have a hard time finding the abnormal gland. It's important not to rely on these imaging tests to be successful for parathyroid surgery. Understanding the anatomy is much more important, and that's how we approach the surgeries here. Next question. How can it be determined if it is primary or secondary hyperparathyroidism? It's a great question. What does that mean? What is secondary hyperparathyroidism? What is primary hyperparathyroidism? Primary hyperparathyroidism means you have one or more diseased parathyroid glands causing overproduction of parathyroid hormone. And that's a surgical disease that needs to be treated surgically. Secondary hyperparathyroidism means you have elevated parathyroid hormone levels, but the glands are not diseased. The glands are actually normal. They're just being stimulated to overproduce hormone from some outside influence. And it's important to make a distinction between the two because in most cases, secondary hyperparathyroidism does not benefit from surgery. Those conditions are managed medically. What are the common causes for secondary hyperparathyroidism? Severe vitamin D deficiency can cause this. And typically the lab data will be normal calcium, elevated parathyroid hormone level, and sometimes a low vitamin D level. Okay, so vitamin D deficiency can do this. Advanced renal failure or end-stage renal disease will do this. Malabsorption problems, the most common we see these days are patients who have undergone a Roux-en-Y gastric bypass operation because you bypass the part of the intestine that absorbs calcium and vitamin D. So it's a lot of the same problems, low calcium, low vitamin D levels. This leads to compensatory parathyroid hormone secretion to compensate for that. There's another secondary cause of this called a renal calcium leak syndrome, where you spill a lot of calcium in the urine. Your calcium levels are low, your PTH goes up to compensate, and they often have low vitamin D levels as well, and they make a lot of kidney stones. So it's important to determine the distinction between those two entities because secondary causes of parathyroid elevation don't need surgery, they just need medical management. Okay, it's a good question. Here's a question from someone in Ireland. I live in Ireland. My calcium is 10.4. I'm using the American concentration there if you're on, if this person is on listening. My PTH is 85. I was originally told I had primary hyperparathyroidism, but now my endocrinologist is saying that calcium is not high enough. I have osteopenia, which means some bone loss, and many other symptoms. From what I understand, hyperparathyroidism cannot disappear. I am confused. What do you suggest? That lab data, just to be clear, is consistent with hyperparathyroidism. There's no question that you have hyperparathyroidism. And the concept of your calcium not being high enough is something that we run into in this country a lot. We hear this from patients being told by their doctors the exact same thing. With the notion being that if the calcium isn't, it's how high your calcium is that determines how bad your parathyroid disease is. If it's only a little high, it doesn't matter. We can just watch it. The reality is, it's not how high your calcium levels are. It's how long you've had the disease. So calcium levels that are even a couple tenths of a point elevated is just as bad as if it's 2 points above normal. Okay, what matters is if your calcium is high or not. It's either high or it isn't. If it's high, then it's bad for you, okay, and needs to be treated. The longer you have parathyroid disease, the worse it is for you, okay? So this patient in Ireland, you have this disease and you should not let your endocrinologist talk you out of being treated for it. Let's see, what's next? This is a great question. I've had high calcium, most recently 11.4 for 7 years at least. My primary care doctor just put me on a large dose of daily vitamin D, which he says will help correct the hypercalcemia. Is this a correct course of action? I feel terrible. This question is a great question. It drives me crazy. We see this mistake made all the time. And vitamin D is involved in parathyroid physiology, okay, in the following way. Parathyroid hormone converts your vitamin D to a more active form, which allows you to absorb calcium from your GI tract. It's one of the ways it raises your calcium levels back up to normal when it's too low. So people who have hyperparathyroidism and overproduce parathyroid hormone constantly are depleting their vitamin D by converting it to a different form. So it's almost always low in patients who have hyperparathyroidism. Okay, and these doctors see the low vitamin D and say, oh, you might have vitamin D deficiency. Let's correct that and make sure that's not the problem. it's important to make a distinction here. Low vitamin D can make your PTH values go up, but it never, ever, ever causes hypercalcemia, ever. And medical doctors and endocrinologists should know that. They should understand that physiology. So someone who has high calcium of 11.4, like this patient, with high PTH values, and they're getting vitamin D repletion to try to fix the problem, that can't work, will not work. And it usually makes patients feel worse symptomatically. So don't let your doctors try to replete your vitamin D to correct your hypercalcemia. It never will work, and it just means they don't understand the physiology here. This patient has hyperparathyroidism. They should not take vitamin D, and they should seek out surgical care. Okay? Great question. Thank you for that one. Okay, here's another one. My calcium and PTH levels are high, 10.8 and 182. So that's a very obvious diagnosis of hyperparathyroidism. I am suffering from many symptoms. My primary care doctor believes I have cancer. After watching your videos, I'm thinking it could be hyperparathyroidism and not cancer. What would you recommend I do next? So I see this mistake made as well fairly frequently. And a doctor will see the high calcium, and because malignancy can cause hypercalcemia, they will freak the patient out by saying, oh, you might have cancer. We have to do all this testing to make sure you don't. The simplest thing to do is to check a PTH value. So in this patient's case, they already have one that's 182. If you have hypercalcemia of malignancy or any reason that's not related to parathyroid disease, your PTH values will be suppressed by the high calcium. They'll be very low, like in the single digits usually. So if a doctor sees a high calcium and wants to make sure you don't have cancer, all you have to do is check a PTH. If it's normal or elevated, then that rules out cancer immediately. And so this patient doesn't have cancer. They have hyperparathyroidism. It just needs to be treated. There's another part of this question that talked about the doctor was awaiting the results of a thyroid biopsy. I'm not sure if that was just a separate issue or not. But a thyroid cancer does not cause hypercalcemia, to be clear. Okay. I had parathyroid surgery in March as well as a thyroid lobectomy. All my symptoms are back. What do I do? How much time needs to pass, and how many labs do you require to accept a reoperative patient? I'm going to, for the sake of the question, assume that you have lab data that shows that you have recurrence. Let's assume that. So if you've had an operation or a parathyroid operation and your labs sometime in the short term after surgery show that you are not fixed, you still have the disease, how much time needs to pass before considering another operation? It depends a little bit. It's a complicated answer to that question. It depends on what kind of surgery was done. Did they look or operate on both sides of the neck? How much surgery did they do, et cetera? So it's important to know the details of the operation before answering that question. But in general, we try not to proceed with a second operation in the neck until at least 6 months has gone by. So to let all of the inflammatory changes of healing just completely subside, because it's going to be very difficult to reoperate under those conditions. It doesn't have to be 6 months, depending on the circumstance, but usually 6 months or more. Okay. What do I do if you still have the disease and have had an unsuccessful surgery? Reach out to us. I would love to evaluate your case. It's my biggest area of interest is solving these reoperative parathyroid surgeries. Okay. I mean, this is an appropriate question for right now. I want to come to see you from overseas, but I'm scared to travel to Florida because of the hurricanes. Is it safe? Today, it's safe today. We obviously had a hurricane hit Florida, for those of you who don't know, recently with some pretty bad devastation. For this patient, I will tell you that the hurricane season lasts until the end of November. So if you're concerned about hurricanes and want to come, you can certainly do a consultation with us, but delay coming for the surgery if that's what you're planning on doing until after November. Okay. Okay, here's another good question. I've suffered with high calcium for so long, and I know I need to be treated. However, I'm scared to death. It seems like a risky surgery to me with the risk of damaging the laryngeal nerve and hypocalcemia. How do you mitigate those risks during surgery, and how is what you do different than what other surgeons do? That could be a pretty long answer. So a couple things. In experienced hands, parathyroid surgery is very safe. Okay, any surgery can have problems or complications, and this is no different. There's really three complications that you can have. General surgical risk like infection or bleeding are possible, but incredibly rare with this operation. Changes to the voice, or what this patient is referring to, or damage to the recurrent laryngeal nerves. We always operate near these nerves when we do these cases because that's where the parathyroids are. These are the nerves that control or innervate the musculature to the larynx and therefore control your vocal cords and your voice. Any parathyroid surgeon is always very careful to protect those nerves and keep them safe. But if you're inexperienced, it can be relatively easy to injure them by accident. Surgeons in this practice, like myself, who have performed nearly 10,000 of these operations, a comfort level with the anatomy is achieved where inadvertent injury to these nerves really doesn't happen. So the risk of injury to the nerves is essentially zero. Occasionally, the nerves can be irritated by surgery occurring near them, and they can have temporary dysfunction. That doesn't happen rarely to one of our patients, but this is almost always a temporary problem. In general, for those of you who are scared about the operation, it is very safe. Complications occur in about 1 in 600 patients, the things that I mentioned. You mentioned specifically the potential for hypocalcemia. Almost all patients who have successful surgery have hypocalcemia for a couple of weeks after surgery. That's expected. Permanent hypocalcemia, we just don't see it, okay? So try to keep that in mind as you think about getting treated. The risks of not being treated, to be honest, are much, much higher than your risk for being treated with the operation. My bone density scan shows significant osteoporosis. Can you explain how the hyperparathyroid condition affects my bone remodeling processes and how surgery can help prevent further bone loss? Great question. This is one of the big things that untreated parathyroid disease can cause. And this is how it works. Okay, bone loss is a common problem for people who have untreated parathyroid disease. Why does it happen? One of the things that parathyroid hormone does, and again, its only job is to raise low calcium levels back up to normal. That's all parathyroid hormone does. One of the ways it does that is by activating cells in your skeleton that are usually dormant. These cells are called osteoclasts. Okay, and when you need calcium, the skeleton is the biggest storage depot in your body for calcium. Parathyroid hormone activates these cells, and all osteoclasts do is release enzymes that dissolve your bones, dissolve bone mineral, and release those into your bloodstream, including calcium. In little short spurts, that's okay. Doesn't cause any appreciable bone loss, but for people who have hyperparathyroidism and are constantly overproducing this hormone, you are essentially telling your skeleton to dissolve itself continuously. And that's why bone loss occurs in patients with the disease. How does surgery help prevent further bone loss? Number one, as soon as your parathyroid hormones levels drop, which happens within 30 minutes of the operation if it's successful, that process stops instantly. So the accelerated bone loss stops immediately. And typically, bone density improves in most patients in the ensuing number of years after surgery. One of the reasons that patients' calcium tends to run low for a couple of weeks after surgery is because this process begins. The skeleton, now that it can, starts to actively siphon calcium out of your bloodstream back into itself. And so after surgery, you start to lose calcium levels from the blood because your bones are sucking it up, and you don't have normal parathyroid glands that are functioning yet to counteract that. So calcium tends to run low for a couple of weeks, that's why. Okay, that's a great question. Next question. How are we doing on time? We're doing pretty good? Okay, let's keep going. Could cinacalcet, okay, the brand name of this drug is Sensipar, this is a calcium mimetic drug, or bisphosphonates. These are drugs used for bone, for people with bone loss. It's an anti-resorptive medication. Can these drugs be used to manage my condition if I'm not a candidate for surgery? I have a heart condition, I'm not sure I can go under anesthesia. First of all, you have to be pretty sick cardiopulmonary-wise to not be able to tolerate this operation. Okay, the reasons that patients get into trouble with heart conditions or lung conditions after big surgeries is because of the fluid shifts that occur in the body afterwards. It puts a lot of strain on the heart when all that fluid gets absorbed back into your vascular system. That doesn't happen with parathyroid operations. So you can have a pretty serious heart condition, you can have lung problems, and you can do just fine with this operation. So there are very few people who can't tolerate it safely. But the question itself about these drugs, cinacalcet was a drug that was developed for the treatment of renal failure-related hyperparathyroidism, as secondary hyperparathyroidism. It's not indicated for primary hyperparathyroidism, and it doesn't do anything to treat the disease, actually. So cinacalcet or Sensipar is not a good option for treating this. If you truly cannot undergo parathyroid surgery and your calcium levels are dangerously high, like 14, then sometimes these drugs can at least lower that level to a safe level. But in general, cinacalcet and bisphosphonates don't treat hyperparathyroidism. Okay, good question. Let's see. Okay. Here's one. I have a long history of kidney stones. Could you explain how surgery might lower my future risk of developing more? So while not everybody with hyperparathyroidism develops kidney stones, it's one of the things that can happen when you have parathyroid disease. And why does it happen? When you overproduce parathyroid hormone, it leads to hypercalcemia, as I'm sure most people listening know. In some cases, that extra calcium in the bloodstream can overwhelm the kidney's ability to manage it, and so you tend to spill a lot of calcium in the urine. And that all of that calcium flowing through the kidney collecting tubules over time can lead to kidney stone formation. The extra calcium can combine with other substances in the urine to form kidney stones. How does treating surgery or treating a parathyroid disease help mitigate the risk of developing more? By correcting that problem. As soon as your calcium levels normalize, that nidus for kidney stone formation resolves, and it's generally not a problem anymore. Okay. I'm being influenced by my last question I have time for. Okay. I have had 2 surgeries and only have 1 gland remaining. What are the treatment options for me? I'm going to assume that you still have hyperparathyroidism. This is an unfortunate problem that I've run into a number of times in my career at this point, where patients have had all of their glands or all normal glands removed, leaving only a tumor or an abnormal gland. And so this is a challenge, because the goal of any parathyroid operation is to cure the hyperparathyroidism, obviously, while maintaining normal parathyroid function, because you really need to have that. So what can you do if you only have a tumor left? You only have an abnormal parathyroid gland and no normal glands to provide normal function afterwards. And there are ways to manage it. There's a couple of options. Assuming we know where your parathyroid tumor is, option number 1 is to remove it completely and auto-transplant some of that parathyroid tissue into a muscle in your body. Somebody, believe it or not, a long time ago figured out that if you chop up parathyroid tissue, abnormal parathyroid tissue from a tumor into tiny little pieces and put it in a pocket of any skeletal muscle, those parathyroid pieces will actually work. They'll make hormone, it will get into your bloodstream, and will actually provide normal function. So that's one option. The other option is to leave a small portion of that tumor remaining in the neck attached to its vascular supply. What are the pros and cons of those 2 approaches? If you do the complete removal with auto-transplantation into muscle, there's a chance that it won't work. It almost always does, but sometimes it doesn't. That transplant doesn't take and it doesn't function. And even if it does function, it usually takes 6 months to a year. So you're guaranteed to have a period of hypoparathyroidism, and it may be permanent. Leaving a portion of the tumor in the neck attached to its vascular supply, what are the pros and cons to that? The pro is that it'll function. We know it's going to work, so you won't have any hypoparathyroidism. The con is that tumor will grow over time and cause recurrence. Depending on where that gland is located, it's not necessarily a difficult problem to manage in the future. But those are the 2 options for someone in your situation. It is manageable, and those are the two ways that you can manage it, okay? And I think that's all the time we have today. So I apologize for the technical difficulties we had earlier. Thanks for those who stuck with us. And thanks to everybody for joining us for another question and answer session. I hope you found it helpful. We'll come back and do this again in about 6 weeks, and send your questions in, and I look forward to the next time. Okay, otherwise have a great day.